Good flexitor? Yeah. All right, let's go ahead and get started. So before we start with the lecture today, we'll kind of finish up just one topic from yesterday. Okay, and then we'll get rolling with the next set. Any concerns, questions, comments? Laughing? You laughing at me? No, okay. It's okay. It's free game. How many people, right? You don't have to raise your hand, but how many people feel that the homework, as I've heard it referred to as, is not valuable? All right, think about it to yourself. Don't raise your hand. Okay? But I will tell you this: if you do your homework, okay, assignment. I like to call them activities now, right? Because the last junior class was sensitive to the word science. So, I promise you that you'll see value added. Okay? Make sense? So I will tell you that I keep pushing the deadline back to submit for submission, right? What's the purpose of that? Because again, I don't want you to feel threatened by it. Okay? If you feel threatened by it, then I don't know what that is, because you guys use that assignment to study. That's what I told you guys, right? It's not for a grade. You can't necessarily get anything wrong on it, right? When you submit it, I'll look it over. If something is wrong, I'll just give you some feedback. And that's it. We'll move on with our lives, okay? Does that make sense? So that, again, the assignments, activities are not meant to be threatening, okay? So take it for what it is. You know, and I know this won't make you feel better, but there was a lot to this course that I removed. So you have 10% of what used to be there. 2%, I don't know, small percent, okay? Because again, I realized that your time is valuable. I told you guys that I respect your time. On that note, I know that I've been going over a little bit, and I apologize for that. I've been having some computer issues, some the normal Canvas stuff, but on top of it, they decided to do an upgrade. But I am aware, okay? So don't feel like I'm just like gonna beat you guys into the ground, right? Like I was talking to the guy back there who's laughing right now. You know, I said, I realize you guys just want to get done with this and get back to studying for ID, right? Again, don't raise your hand, don't answer. This is being recorded. But, so I'm aware of that, okay, guys? I'm here to carry you guys if I need to across that finish line next year, okay? So you need to feel that, you need to understand that, okay? I'm not here, again, to beat you into the ground. Any concerns about anything we lectured on yesterday? Of course not. So sprains and strains. So this is important terminology because a sprain is not a strain, correct? So the way I always teach it to people is that a ligament is different than a muscle. We all know that. So therefore, they can have different injury patterns. So with muscles, do we have strains or sprains? Okay, of course, it's on the screen, right? So the way I teach it is the word ligament has a T, right? The word strain has a T. We all agree on that? The two T's can never exist together. Ever. Okay? So if you have a strain, it can't be a ligament, correct? It's a muscle. Are we good with that? So hopefully you'll remember that going forward whenever you're thinking about anything when it comes to ligaments versus muscles. Okay? So therefore, if we agree that strains are muscles, then we also agree that there's a classification system for it. Right? So it's grades 1 through 4. I'm not going to read that to you up there. You guys can see it. I concised it. I made it more concise. Excuse me, concised it. That's not a word. I made it more concise so you guys can see that. But understand, muscles have 4 grades. Ligaments have 3. Muscles have 4 grades. Ligaments have 3. But the thing that's common to them is that the most significant one, so a muscle grade 4, and a ligament grade 3 means there's 100% disruption. That's consistent. Are we good with that? Okay? So there's a little picture there that's meant to tell you that, again, a strain is an injury to a muscle or tendon, right? And then a sprain is an injury to a ligament. Okay? So that's going to be important when you guys are looking at test questions, potentially, very soon. Okay? And you're looking at it, and I give you a grade. And you have to think about what that grade is and decide potentially what the management is of that. So if it's a grade 3 muscle strain, is it a complete 100% disruption? No. Okay, I did that on purpose. Okay, I put the next slide up there to throw you guys off. All right, so a grade 3 is what? 50 to 100%. Make sense? Okay, now I'll go forward and I go to sprains and ligaments. A grade 3 is a complete disruption. Would you agree on that? Okay, got you. Okay, so think about it in terms of muscles versus ligaments. And again, muscles 4 grades, ligaments 3 grades. You good with that? And notice how we don't necessarily use percentages. We say, we start introducing in ligaments, specifically grades 1 through 3, we start introducing this concept of instability. Okay, so when you guys are down in the lab, next block, and you're doing your testing, you're testing for what? Laxity and or instability. Make sense? So that's how you're going to grade it. Okay? So there's an example I put up there. I did add that, right, just to conceptualize things for you guys. There is a MCL up there, okay? Medial collateral ligament. So we all agree that there's a lateral collateral ligament as well, right? Well, we know that patients have 2 of both, right? 2 of each, 2 of each, right? So you have, if you test one side and you decide what grade you think it is, do you test the other side? Yes. Yes. Then you reconsider what grade you think it is. Because some people are loose, not in character, in ligamentous laxity. Does that make sense? Okay. I got a few laughs. All right, talk about today. So pediatrics, the only thing I'll introduce right now, right, is this concept that in pediatrics, sprains in children are uncommon. So whenever I get a referral for somebody that says that a patient has a sprain, I'm thinking to myself, fracture until I prove otherwise. Specifically, what type of fracture? Well, if you can't see an overt fracture, you guys remember Salter-Harris? Okay, so Salter-Harris one fractures, can you necessarily see a fracture? No, right? But again, just think to yourself, is this a sprain or is this an occult Salter-Harris one fracture? Okay? You good with that for now? You guys will get more to Salter-Harris in block 4. Okay? That's it. So symptoms, here comes that snap, crackle, pop, right? So you're going to ask patients on your history, did you, at the time of injury, right, trauma, did you experience what? Popping, snapping, or tearing sensation? A lot of times I'll describe that to you. So that should key you in to the fact that they may have, for example, an MCL injury, correct? And they said they felt a pop to the medial aspect of the knee. Followed by pain, swelling, stiffness, and difficulty bearing weight. Okay? So if it's an injury to a tendon, it says there that you can have bleeding. Is the bleeding immediate? Not necessarily. Right? So remember we talked about OPQRST, so the timing of the injury is important there. Okay? So again, if you have ligamentous laxity, you can have joint changes and instability. If you have laxity in a joint, do you think that the biomechanics are changed and that therefore they can have different wear and tear? Absolutely, right? So that's what that's getting at there. And then obviously if it's a muscle belly especially, not just the tendon, but the muscle belly, you can have significant weakness, or if it's long enough period of time, you can have atrophy. And when we get into shoulders, we'll talk about rotator cuff injuries and how atrophy plays a part in that, okay? We go with that? So physical exam-wise, the only thing I want to highlight here really is that, again, stability. When you're doing your special testing, it's not all testing for pain. If you're documenting positive tests just based on pain, that may not necessarily be what you're supposed to be evaluating. It's more stability, versus laxity. Good to go? Okay, so obviously it says there, always compare with the uninjured extremity. Okay? What does that mean by palpate for defect? Well, if you feel along the muscle belly, and all of a sudden you feel muscle belly, then all of a sudden you feel your fingers go into that area, so a depression, right? A gap, if you will. Then you can have a muscle defect. That's what that's getting at. Okay, and we'll get into that again when we start talking about specific pathologies. This picture is just denoting, these pictures, excuse me, are just denoting different special tests for different joints and tests for laxity. We'll get into those. Plain film radiographs, of course, you're going to get those on every injury, correct? Okay. So the Ottawa ankle rules, have you guys dipped into that just a little bit? Maybe in radiology? No? Okay, that's fair. I will not test you on Ottawa ankle rules in this block. Okay? But that will become pertinent when we talk about lower extremity. But just understand when we're talking about sprains and strains, what is a very common injury that we see in SPCMs, right? It's ankle sprains, correct? So then that's where the Ottawa ankle rules kind of play a part. Okay, so it helps you decide what patient should get an x-ray. Okay, in my opinion, every patient should get an x-ray, but I'm ortho. So the joke is we can't see a patient without an x-ray. That's not entirely untrue, okay? But if you have suspected foot or ankle injury, use your Ottawa criteria to decide if you need to get x-rays. So then if you're doing your special testing and you find significant laxity, isn't that where the MRI comes into play? Yes, because the MRI is really good at looking at soft tissues, ligaments, correct? Okay, and also for discerning occult injuries. What do we mean by occult injuries? So, I'm sorry, you were going to answer. Hidden, undeclared, right? So an injury that hasn't necessarily declared itself to you, and so you're going to investigate further, you are correct. If you're going to investigate further, an MRI is a useful thing, right? Do we MRI everybody? No, you MRI based on your physical exam and your clinical suspicion, okay? Here's your Ottawa ankle rules. I just put them up there for you guys. This, like I said, will come more into bear in block 4 with Colonel Sylvester, okay? But I wanted to give you guys a nice clean slide that has it on there, okay? So store that away. Non-operative, obviously, right? They're supposed to clench down when you do the anterior motion posteriorly, correct? Everybody understands what I mean by that? Okay, so that's what they're getting at. Decrease rectal tone. Okay. Is that test as reliable for females as it is for males? The answer in this case, Mr. Brown, is no. Okay. You did. Yes. But I just wanted to be clear. I did go against my will. Okay. So it's not as accurate, but that's not testable. I just want you to know that because you may see that arrow. Okay, so you're going to get x-rays, of course. AP, lateral, and obliques. We talked about this. Identifying structural problems. Here we come into your homework assignment, as you guys like to call it. Right? Now that you know what those things are, you look at this slide now, and you say, oh, that's why he wanted me to do that assignment. Excuse me, activity. Right? Because I'm looking for spondylolisthesis. I'm looking for spondylolysis. Spondylolysis is fracture, correct? That's a break. Right? That's in that supplemental slide I gave you guys. So I will often give you something once, give it to you a second time, and then put it all together the third time. Okay? MRIs, that's what you're going to get. You're going to get x-rays looking for what? Fractures, other pathology. But because you have significant neurologic deficits, you will get an MRI. Okay? You will get an MRI. Right? So what you're looking for is marked compression of the thecal sac. Okay? Again, that dural sac. Right? Okay? And if a patient can't undergo an MRI, foot stomp, they're going to get CT with myelogram. Why myelogram? We've already said that myelo refers to the spinal cord, correct? Okay. Laboratory, always CBC, CBC, CRP, ESR, just concern for infection. So like an epidural abscess, that's what we talked about, right? Okay. We go with this so far? Chronic quina, you will see again. You need to know chronic quina. Well, so if you don't treat it, you don't catch it fast enough, it leads to permanent paralysis. That's a bad thing, right? Yes. So this is a time-sensitive condition. The sooner you get alerted and catch on to what you think is going on and make the diagnosis, the better the prognosis is for the patient, okay? Permanent loss of bladder anal sphincter function, well, yeah, that's, again, those deficits, right? Referral decisions, you will always refer this. Always, right? Now, when I mean referral, somebody asked me last go around, you're not literally going to put a referral into Genesis, right? You're going to call somebody. So think of the word referral as consultation. So it's an emergent consultation with orthopedics versus neurosurgery, because not everywhere in the world has ortho spine. There's only like 4 that I'm tracking on right now between the Army and the Air Force. There's not that many, okay, guys? The Navy has even less. But there's quite a few neurosurgeons out there. So why is that a surgical emergency? Because it requires immediate decompression. Okay? Immediate decompression. You need to take that compression that's being caused by either a herniation, by a burst fracture, by an epidural abscess, and relieve that. Good to go? Okay, and then the stuff on the right is, again, getting to what we talked about before. The one thing I will tell you, we get oftentimes, I don't like it when we go down for a consult in the emergency room, and somebody says, I think this guy has caught Aquinas syndrome, and they gave narcotics. Is it difficult to do a neurologic assessment, specifically sensation, once a patient's been administered narcotics?
Yes.
Yes. I thought that in there for you. We are aspiring people, right? Keep that in mind. Okay? So if they have decreasing pain with increasing neurologic deficit, why do they have decreasing pain but increasing neurologic deficit? Well, guess what? Their sensation's going away, right? But the deficits are getting worse, right? So it's motor deficits, specifically reflexes. Okay? Make sense? Okay. Cervical radiculopathy. Now we're going to switch gears and we're going to talk about the C-spine again. Okay? So C-spine, this is exiting nerve compression, not central canal nerve compression. This is how it's different, right? Because in this one, oftentimes, you have symptoms in the distribution of cervical nerve root specifically. So for example, C5, C6, C7, C8, or T1. Okay, so you can kind of pinpoint this a little bit more. In young people, this is often due to what? Disc herniation, right? When I say young, I like to include myself in that category, right? But then when you talk about old, it can be due to osteophytes at the foramen. That's that canal, right? We talk about that opening, okay, where the nerve exits. So they have actual bone spurs that encroach upon that nerve root as it exits. Pain, paresthesias, with or without numbness. Let's talk about this. Paresthesias. A lot of times we like to think about paresthesias as numbness and tingling, correct? More accurate, paresthesias is actually tingling, burning, tingling, right? Sharp, dull, alternating. And then numbness is what they can't feel. Okay? And if it's bad enough, you have that, profound numbness, they can't feel at all. So it's a degree. Right? So you can have paresthesias and not have numbness necessarily. They can have tingling, but they still have sensation. Does that make sense? So if they're having tingling, that's a good thing, right? They still have some sensation. It's just intermittent. But once they go to numbness, that's more significant finding, correct? Does that make sense? Now maybe a little bit against what you guys think of, so we can circle back to that if we need to, okay? But again, when you're doing your testing, you're looking for weakness or loss of reflexes. If they lose a reflex, that's bad, right? That means that the encroachment, compression along that cervical nerve root is significant, okay? Again, this picture denotes that donut with the jelly, right at the bottom right there. See how the jelly's coming out of the donut? It's encroaching on the left side, correct? Okay. Do you agree back there that that's the left side? Is she looking? No? All right. So cervical radiculopathy. So this is where if you're given a scenario, and I'm prepping you, right? Not just for pants, but for the future. If you're given a scenario and it tells you that there's a specific distribution in the symptoms, it may tell you a reflex, it may tell you motor, and then you have to figure out what the sensation is. Okay? Does that make sense? Neck pain plus unilateral radicular symptoms in the upper extremity. That's your key definition there. I'm not going to read all those symptoms, but you do see that it's kind of varied, right? You can have a lot of clinical symptoms there. Right? So coordination is one of them. Hand grip weakness. So you ask the patient, do you have trouble turning doorknobs? Okay? If that's baseline for them, then that's not helpful. But if it's something that's changed, something that's different, then that can show progression of pathology. Okay? Occipital headaches. Okay? Radiating pain to paraspinal and scapular regions. A lot of times that's when you start getting a little bit down further. It's that C5, T1 region. Okay? I'll throw that in as an FYI. That's all. Okay? Pain relief when placing hands on top of their head. So you guys would agree, right? That if you have your arms down like this, right, and you're specifically if you're pulling down, that's putting tension on those nerves, right? So then when you lift your arms up, it relieves that tension because it's not pulling down the nerves anymore. Okay? So think of it like that, like spaghetti, right? If you have spaghetti, a glob of spaghetti in your hand, right, and it's on tension, if you take the ends of those spaghetti and you lift them up, you relieve that tension, correct? So that's what you're doing. You're basically taking those nerves, right, and you're putting them on decreased tension. You're relieving that tension that's there based on the person having their arms down at their side. Are we good with that analogy? Okay, so that may be pertinent. You may be given a scenario on pants that says their pain is relieved by placing their hands on top of their head. That's what they're getting at with that. Okay? Outcomes of disease. Well, if you catch it early enough and you start treatment, hopefully they don't get to this point, right? Paralysis, weakness, chronic pain syndrome. That chronic pain syndrome is not ortho, okay? That's pain management, right? We can't really do much about that either. So, but if they progress to myelopathy with spinal cord involvement, did we say that cervical radiculopathy is myelopathy? No, we didn't, right? So now that disease has progressed so far where not only is it affecting that nerve root as it exits, but it's infecting the spinal cord. Make sense? Okay, so we've gone from radiculopathy to myelopathy. So refer to ortho neurosurgery depending on where you are. Okay? Things change depending on where you are. This chart I gave to you already. Okay? You need to know these charts. There, if you look in your book, because I know you guys have looked in your book, right? You'll see these charts. That's where I got them from. That's where they came from, I should say. Okay? So you do a complete neurologic exam and you decide what distribution their symptoms are. What distribution is their numbness in? Paresthesias versus numbness, right? What distribution is their motor weakness in? Right? If there's a reflex associated with that distribution, is that reflex absent or diminished? Or I should say diminished or absent, right? So you see that word reduced cervical lordosis there again? Okay, I gave you guys that supplemental slide. So a lot of times if you see that reduced lordosis, that could be an indication that they have spasm, right? So those paraspinal muscles are spasm. So if that happens, then they can have more compression of the nerve roots as well. Okay? Diagnostic testing, always going to get radiographs, correct? So they may show arthritis or degeneration of what? We talked about this before. The disc and or the facets. You guys now understand where the facets are and how they articulate and the fact that there could be osteoarthritis associated with facets, right? Okay, good. The answer is yes. So MRI without contrast, okay? Don't worry about the with or without contrast necessarily, but I will tell you this. Do you need to get contrast if you don't think it's infection? Not necessarily, okay? But a lot of times, again, I know someone already mentioned to me, we were taught, MRIs with and without contrast. I would say it's faster to get an MRI without contrast, correct? Because you don't have to give contrast. Duh. But axial cuts will show that nerve compression, and we talked about this in the spine imaging, right? And there's a nice little picture there too. Hopefully you guys can see that. The red arrow tells the story. Okay, where you can see that compression as it exits, okay? And then if a patient is unable to undergo an MRI for reasons, right? For example, if they have metal in their body, certain kinds of metals, I should say, can they undergo an MRI? No. Is this a surgical emergency?
Yes.
No.
No?
Not necessarily. Unless it's progressed to the point where it has absent reflexes, right? And maybe you're thinking about that. So if you want to send somebody to get an MRI, but they're claustrophobic, is that an issue? Yeah, right? So you may opt to do a CT with myelogram. So the concept is MRI is for everybody, unless you cannot get it, then you get a CT myelogram. Good to go? Does the CT scanner still have a tube that they must get in? Yes. So the claustrophobia thing is still a question mark, right? So nerve conduction studies, okay, so electromyogram / nerve conduction velocities, okay? One is looking for the muscles, right? And one, the EMG specifically, is looking at the electromyograms, the muscles, and the NCV is looking at the conduction from one point to another. Okay? That's why you order those tests together. Now you see that little demonstration there of the proximal stimulation versus the distal stimulation? So they're stimulating from proximal to distal and distal to proximal to see if there's a conduction issue. Right? Do we all understand what the word latency means? So that means there's a decrease, right? There's a difference. So if there's a difference, guys, do you think it's important to get EMG, nerve conduction, velocity testing on both extremities?
Yes.
Yes. So you would test the unaffected and the affected side and compare. Okay? That is an aside FYI. But I'm just telling you, EMG, nerve conduction, velocity. So that can help identify the location of the neurologic dysfunction. So if it's still in question as to what level it's at, this can help you with that. Do we have peripheral vascular diseases that mimic cervical radiculopathy? Yes. Those can also help you differentiate between neurologic and vascular. Okay? Non-operative, all this stuff you already know. The one thing I will tell you, don't use narcotics, right, off the bat. Okay? Because it's tough to manage that. Narcotics you should reserve for more refractory or more significant pathology. Okay? But the big thing too is no manipulation. No manipulation. No manipulation. You don't want to be cranking on the neck and making things worse. Okay? Then somebody's like, well, I love my chiropractor. That's fine. I'm just telling you that the cornerstone of orthopedics is not to do manipulation on people that have significant cervical radiculopathy. Okay? So if you're going to do surgery, once it gets to a point where they have more progressed symptoms, so it's not that intermittent neuropathy anymore, cervical radiculopathy, right? Now it's pervasive. It's present most times. It affects what three things? Work, play, and sleep, right? We talked about that. Then we talk about decompression plus or minus fusion. So that little picture there, what that's denoting there is what's called ACDF. Anterior cervical discectomy and fusion. That's what it's saying. If you look at the picture closely, you can see that that disc where the plate spans is absent. It's not white there anymore, right? That disc is gone. They took it out. Okay? You don't need to know that. But that's what that operative is denoting. Okay? It's in yellow again. So cervical radiculopathy can be made worse by manipulation. Don't do it. Right? If the disease process is present long enough, they can have quadriparesis, they can have herniation of the intervertebral discs, strokes, fractures, the list is long. Okay? I always talk about the risks of NSAIDs. Make sure you're choosing the appropriate NSAIDs, appropriate dosing for the patient that you're treating. Okay, look at their medication list, look at their comorbidities. And then post-op complications are always possible, right? Always put it on the surgery, guys. Okay? Let's break. Let's come back. Okay. So when we talk about cervical strains, we already defined strains versus sprains, correct? So we would agree that this is a muscle or tendon, right? And it's not a ligament, correct? But when it comes to cervical strain, the definition I condensed for you guys is what? It's basically not cervical radiculopathy, okay? You need to differentiate those two, okay? This is a common self-limiting condition, okay? A lot of times we call these neck sprains, correct? Or sometimes we'll use the word neck strain, okay? So what is it, strain versus sprain? It's very difficult to really nail it down, correct? I mean, it's hard. There's a lot of ligaments, a lot of structures in that area, in the neck region, upper shoulder. Okay, so the point I'm trying to make is it's not cervical radiculopathy, and as it says there, the protocols for treatment are very similar. So really, it's you deciding whether or not you feel it's an acute strain / sprain, and not cervical radiculopathy. Oh, by the way, definitely not cauda equina, right? Okay, so we're good with that definition? So whiplash is what we think of when we think of cervical strains, right? So that's that coup contra coup, that's that acceleration, deceleration motion that causes things to get stretched out, and then compressed, and then potentially stretched back out, correct? Okay? Rapid flexion extension is what it says there. So this is area of high litigation, right? Lawyers love whiplash injury, all right? Because they're involved with motor vehicle accidents. Insurance companies have a lot of money, right? Okay, so there's a lot of money out there to go after. So this is non-radicular. Is cervical radiculopathy radicular? Well, it's called radiculopathy, right? So there you go, right? And non-focal neck pain. What that means is somebody may tell you that they have pain here, right? They're just going to point to a general area, not pain in a certain distribution. We good with that definition? Okay, so that's what we mean by non-focal. So it can be anywhere from the base of the skull to the cervical-thoracic junction. Also, anteriorly, it can be the sternocleidomastoid, that's the SCM. And then more superior and posterior can be trapezius, right? Meaning that there's a trapezius muscle on both sides, correct? Okay? So occipital headaches can occur early and persist for months. Okay, so that's associated with these neck strain sprains. And increased irritability, fatigue, sleep disturbances, and difficulty concentrating. Well, that sounds like a typical IPAP student. So that doesn't get us anywhere, right? Right? But when you're doing your physical exam, you're going to feel areas of tension versus spasm, right? And so when you're palpating areas like the paraspinal musculature, you can feel tightness, spasm, right? You can feel what's called trigger points, which is very specific points of the trapezius muscle that you feel tension, and when you poke at it with your finger, it responds. Okay, that's why they're called trigger points. Okay, meaning there's tension there. Okay, the interspinous ligaments, are those easy to assess on physical exam? No. Okay, so again, this is just more talking about that you're saying that you suspect that it is non-radicular in nature, and you believe it's either a strain or a sprain. Okay, decreased range of motion can be due to that spasm. So obviously, if they spaz up, right, and they're having trouble turning their neck and looking from right to left, or looking up, I just popped. Then that's what we're talking about there, right? It can be a little bit of increased tension, i.e. spasm, okay? But, again, conversely, neurologic exam is completely normal. Okay? Are we good with that? So, rule out fracture. Obviously, you're going to get x-rays, right? At some point. Okay, you're concerned. And you're going to rule out pathology, okay? AP lateral, there's that odontoid view. That's that open mouth view, correct? Now, getting back to the lab. So that's the reason we knocked that out, okay? Can there be associated neurologic deficit? Maybe. But a lot of times with this, it's both minimal and short-lasting. Okay? Elderly patients tend to have this more so. Can they have, have osteoarthritis? Yes. And they can be more prone to this. You're going to get films on elderly patients. Why? Because elderly patients are more prone to fractures, correct? We talked about osteoporosis, right? So are they more prone to compression fractures? Yes, they are. And we'll get into that pathology a little bit more later. All 7 vertebrae must be seen on the film. We talked about that as well. So making sure you can see all levels and the top of T1, correct? Not flexion extension views. If somebody comes in and they're having significant difficulty with flexing their neck, are you going to force them to go to radiology and go into terminal flexion to get a good flexion, and then conversely terminal extension to get a good extension view? No, don't do it. It's in yellow. Don't do it. Okay? Reassurance is the first and most important part. You tell them this is just a strain or a sprain. Use whichever word you feel is appropriate. And you have no focal deficits. You don't have any weakness. You don't have any concern for cancer. And there's no concern for infection. That's how I tell my patients. Because those are all the bad things, right? That's what people are freaking out about. So reassure them, let them know, hey, this will get better with time. And a little bit of conservative care. What's the conservative care? Again, NSAIDs, RICE, activity modification, and physical therapy. Okay? The acute care phase is usually, what I mean by acute care is the care being given on an outpatient basis, right? Not in an acute care center. So that's that first couple of weeks, 1 to 2 weeks, okay? Muscle relaxers come into play if they have spasm. Just be careful with that, because do muscle relaxers cause sedation? Yes. So if they're driving, operating heavy equipment, right, you may have to give them duty restrictions. So make sure you're aware of that. If it's security forces, military police, anybody who arms up, there may be some considerations there, okay? Soft collar, how often do I use those? Man, I don't know if I have, I'll be honest with you. But does the soft collar create a situation where it takes that weight bearing of the head, right, away? Yes, it does. And it causes them to have a little bit of traction too, a little bit of distraction, if you will. And again, remember, this is not cerebral radiculopathy, so it's okay to use a little bit of gentle traction, okay? But no manipulation. There's a difference between manipulation and traction. Do we agree on that? Manipulation is all that, like, Mr. Miyagi stuff, you know, right? It's a motion to try to relieve, to open up a joint space. Traction is literally, you're just pulling the neck away from the shoulders. Okay, you good with that? Very gentle. But the goal is to return them to activity as soon as possible. Any questions about cervical radiculopathy versus cervical sprain? Okay, of course not. Meningitis, infection. Okay, this is another one of those things where, do you think this is something you might see tested? Absolutely 100%. Okay, so it's important to understand that the terminology, according to academia, according to textbooks, according to your textbook, right, differs whether we're talking about pediatrics or adults. So key in on that as we discuss this, okay? But it's a bacterial infection involving the anterior elements of the spine. We talked about that earlier, right? What are the anterior elements? That's the vertebral body and the discs, right? Good to go? Okay? So vertebral bodies and the discs, not the posterior arch, correct? The answer is yes. So the most common in low thoracic and lumbar spine. Thoracic especially, okay? Especially low thoracic. I'm sorry about you. But here's the terminology stuff, okay? So in kids less than 5 years old, it's referred to as discitis. It's an itis, correct? In adults, we kind of mentioned this before, it's referred, greater than ages 5 years old, excuse me. So it's at 5 years old, right? It's actually oftentimes called vertebral osteomyelitis. That's just a terminology thing, okay? We talked about infectious processes that can occur, like for example, osteomyelitis in older patients and how it tends to live in the vertebra, correct? And we also talked about how the most common organism is what? Staph aureus. So all that stays the same. Would you agree? Okay. This is just understanding where it's happening. Okay. And is it pediatrics, less than 5, or is it a patient that's greater than 5 years old? Okay. Clinical symptoms. The symptoms are oftentimes very difficult to discern. Okay. Fever and malaise are common. So yes, it's infection, correct? Back pain, again, it can be very kind of vague, dull, it hurts in here, okay? Children may perceive the pain to be in the abdomen or thigh. That's something to key on a little bit, because if a pediatric patient tells you they have back pain and also have abdominal or thigh pain, you may be like, huh, that doesn't make sense, right? Limp or refusal to walk, right? So that can be challenging in toddlers, okay? Because sometimes they just don't want to do what you want them to do anyways, okay? All right? Most of the times. You know, my youngest is 14, my oldest is 30. So I still can't get them to do what I tell them to do. So. But low-grade fever is common, okay? See that word low-grade fever? So again, it's not like this raging fever. It's raging elevated temperature a lot of times. So it can be very vague. So on physical exam, when they walk, they lean forward to place their hands on thighs for support. So would you agree that if you lean forward, the spine isn't straight up and down, that axial load on the spine is not as present anymore? It's still present, it's just not the maximal axial load. So what they're basically doing is they're bending forward to relieve the pressure up and down their spine. Are we good with that? Okay. That'll come into play again later. Tenderness to percussion on the spinous processes. So we talked in the lab about identifying where you are on the spine, right? Where you are as far as spinous processes. So this is how you're going to kind of use those skills to zero in on what level you feel it's at. Because it's more common in the lower thoracic and lumbar, correct? So you now all are experts at finding L1. So then you can work your way up or down, depending on where the pain is, and discern a little bit more, correct? Because you order imaging, and the radiologist calls and says, hey, I see some abnormalities about the junction of T12 and L1. Was he tender there? And you can say, yes, he was. He had vocal tenderness there. See how that word focal comes into play now? Okay? Because you did a good exam. Passive range of motion is painful. Again, you are making them go into that motion. They're not going to want to do it. They're going to want to just sit in this position like this to relieve that axial load on their spine, and then you're gonna hold them or lay them down. Be nice, and you're going to try to move them a little bit, and they're going to have severe pain. Correct? Okay. Very painful. Especially with flexion, okay? So disguise as far as imaging, again, I'm not going to give you guys MRI slides on the test, okay? But would you guys agree that if you look hard enough here, right, at this MRI, that you can see this white area here? Is that supposed to be there? No. Is all this white area supposed to be there? No. You guys can agree that inside of the vertebral disc itself, you can see that kind of lucency there. That's an infectious process that's showing, okay? But if you get x-rays, you may not be able to see that right away because it may take weeks. How many weeks does it say there it takes to see changes? 2 to 3, right? So sometimes do we jump to MRIs pretty quick with these? Yes, it's infection, right? Time is tissue. You gotta catch it and you have to treat it, okay? 3-phase bone scan can help establish the diagnosis and localized pathology. That's just another tool you can use, okay? If that's what you have available, especially, or if there's still a question as to what imaging study that the patient can tolerate. But the MRI is the study of choice. It confirms the diagnosis and it defines the extent of the process and complications. So is it really good at defining epidural abscesses? 100%. That's why it's better, okay? Because not only do you see a mass, would you agree that an abscess is a space-occupying mass? Yes, but with the MRI, you can discern and differentiate a little bit more and say that's an abscess. Good with that? What's in yellow, MRI, is this imaging study of choice. Laboratory studies can oftentimes actually not be very helpful with this, okay? This is a central issue, meaning it's your spine. So sometimes you don't see that white blood cell shift. It can be normal in a lot of cases, okay? But the ESR and CLP is still going to be elevated. When we talk about blood and disc space cultures, okay, we're talking about actually going into that space and getting some of that out, and then evaluating it, and then also doing cultures. That's pretty invasive, right? Okay, so one option that we have in our arsenal is to do a CT guided aspiration with culture. So you're literally doing a live CT as you're advancing a needle into that space. There's a lot of badness you can cause, right? But is it something we use very commonly? It depends, okay? But if you are doing empiric treatment, what do we mean by empiric treatment? That means you're treating for the most common organisms, right? Broad spectrum, like things like that. And they're not improving, then you might think a little bit more about doing that, okay? Especially if you think maybe this is actually something else. So you're like, it smells like discitis, but it may actually be this other condition too. Okay, so then again, the best way to discern that is to go right at the source, right to the source. Go right into that abscess and get some of it. Okay, make sense? So outcomes of disease. So if you don't catch it early enough, right, you can have persistent disc space narrowing. So that narrowing that you saw there earlier because of all that infectious process will not be reversed. Okay? You can also have spontaneous vertebral body fusion. So as the body tries to heal post-infection, the osteoblasts, right, osteoclastic activity, it'll cause turnover there. It'll cause abnormal changes in the relationships between the intervertebral vertebrae, okay, between the vertebrae. So it may not be reversed. But the good news is, especially if the patient's younger, is that a lot of times after that, you'll see that in a post-treatment MRI potentially, or CT. A lot of times that's not symptomatic for them, okay? Your book says that too, just so you know. I won't test you on that, but just so you know. You're like, oh my God, this all sounds terrible. Okay, but the big thing is, will the infection kill them eventually? Yes, gotta treat the infection, guys, okay? This is infection. Treatment, if it's non-operative, right? Bed rest, activity restriction. Obviously, we don't want them up and moving around if they're in excruciating pain. That's just not good. Analgesics, judiciously use analgesics, right? Spinal orthosis, brace for 4 to 6 weeks for pain relief. The spinal orthosis, and we'll get this into this a little bit more, but basically it's a big back brace that you put on the patients, okay? And what that does is it causes support and a little bit of compression, but it can also cause a little bit of traction, if you will, a little bit of distraction, depending on what kind of spinal orthosis it is, okay? Antibiotics, 6 weeks total, right? Okay, sure. It depends on how bad the infection is, but initially the IV antibiotics inpatient, so this is not a patient you're going to send home, correct? This is infection, so it's going to be for at least 2 weeks inpatient. And then once they improve, then you do a gradual return to activities. Now, say that it goes on to not respond to treatment. Okay, you've done IV antibiotics and all this stuff, and it doesn't improve, then you move on to the surgical options. Okay? So sometimes if you can't resolve the abscess, because you would agree that an abscess is a walled off bubble of infection somewhere, okay? All right, so that the antibiotics just aren't penetrating. Sometimes you have to go in there, right, and get a good look at what's going on, so you can do a biopsy, right, and then you can debride all that badness away, all that infectious process, and you can discern, okay? And it's just like we talked about yesterday with debriding other body parts when it comes to infection. You debride as far as you need to until you find clean margins, okay? Take away any non-viable tissue, take away as much of the infectious process as you can, and then get out of there, okay? Decompression of an abscess is highlighted there, okay? Referral decisions, neurologic symptoms, usually for an epidural abscess, okay? So we talked about this earlier, right? How if you have compression of the central canal, right, then it can cause neurologic deficits. So if it gets to a point where an abscess is growing, and it gets to a point where it's now causing myelopathy, that's bad, correct? Okay. But you're always going to refer these patients. I can tell you you're not going to manage these in the clinic, right? We already talked about the treatment period of time for these. So all patients will be referred. But you will have a higher level of referral, immediate consultation based on if they have neurologic symptoms, okay? So you may bring more people to play. For example, infectious disease, okay? Lack of response to empiric treatment would suggest that they need additional workup and follow-up, okay? And or biopsy. Good to go? So what that means is that you treat a patient, they seem to improve, right? You send them home, and now they're doing bad again. Do you think then you might do a biopsy if you didn't do one before? Yes. Okay. All right. Any questions about discitis? No questions? All right. Kyphosis is going to be quick. We already kind of talked about this, right? Can we have normal physiologic thoracic kyphosis? Yes. Yeah. Okay. So, but here I talked to you already about this. When we're talking about kyphosis in terms of pathology, we're actually talking about hyperkyphosis, right? There's a normal physiological kyphosis that's present. Okay, but what's the number? Greater than 50 degrees is considered hyperkyphotic. Okay, so if it's greater than 50, then what's normal? Less you is normal, right? 20 to 50. Okay, 20 to 50 is considered normal. And greater than 50 is considered hyperkyphotic. We're good? So what's this due to? Now we always talk about it, right? Your mom, dad, whatever, says you slouch, you stoop, you don't have good posture. So it can be postural. So if you lay them down on a table and flat on their back, what's that called? Supine, correct? So if you lay them supine and all of a sudden that kyphosis corrects itself, would you agree that that's flexible kyphosis? Yes. So that's all that second bullet's saying. It's correctable. Okay? Is that as concerning? No. And girls. I don't want to pick on girls, right? But again, this tends to be a posture thing. Okay? Sherman's disease. This is something you guys need to know. You will see this potentially on pets, and you'll probably see it again soon as well. In my setting, okay, in our setting. All right. So Sherman's disease is a very specific. This is a pediatric condition, and this is not normal postural or physiologic kyphosis. This is actually both morphologically different and pathologically different. So by morphology, I mean the discs themselves look different. You would agree that this little wedge shape here doesn't look like a normal disc, right? Everybody sees the wedge difference between this side and this side, okay? Between this side and this side, there's wedge shape, right? So if you see those wedges like that, does that mean they're going to lean more anteriorly because the more shallow part of the wedge is anterior? Yes, right? So then that can naturally have more kyphosis, right? More than 5 degrees in at least 3 consecutive vertebrae, rigid, uncorrectable, so you lay them down and you're not able to correct that deformity, right? By kyphosis. Make sense? Okay. And this is boys. So more common in boys. Okay? So girls, postural, boys, Sherman's disease. Okay? Any questions about those pictures there? I think those are actually really good pictures. All right. So clinical symptoms, most people come in and these, when it comes to kyphosis in adults, they just say, well, I have lower back pain, or they have some concern for what? Cosmetic concerns. They don't like the way they look because they slouch and they lean. With kids though, who brings them in? The parents, right? So then as astute clinicians, you're going to get x-rays. You're going to see those anterior wedging vertebrae, and you're going to say, I think this patient has Sherman's disease, right? Anterior-related mid-back pain, but it's usually relieved by rest, right? Especially if it's within that 20 to 50 degrees. Would you agree? Of course you do. Neurologic symptoms are uncommon, okay? So this is that physical exam. So everybody can pick out on the bottom here. You see how when they slump forward, there's more of a sharp, acute angle there, right? See that acute, and that's pretty significant, right? That's clinically significant. So that's Sherman's disease. That's what that's showing you there, okay? Neurologic exam, again, is usually normal. Do you think if that curvature gets significant enough, they can have respiratory concerns? Yes. Okay. But again, from a neurological standpoint, for the most part, these patients present with just cosmetic concerns. Okay. This is the imaging we talk about for kyphosis. When we're going to evaluate it, we're talking about doing Cobb angle measurements. All right. Cobb angle measurements are something a radiologist normally does. Okay. And that picture on the right-hand side denotes how they might break it down. So they might look at you might look at that X-ray that you ordered, right? That AP and lateral, the entire spine. Is that seated or standing? Standing, right? You might look at that X-ray and you see those marks that you see there on the right-hand side, and those measurements are done for you. Okay? So the measurements are normally done from T5 to T12. But again, what is abnormal? Greater than 50. Am I going to give you a slide with a X-ray and say, give me your Cobb measurement? No. Who wants it? You want it? No? Okay. Brown said yes, so I'll give you one. Just kidding for the recording. So we're talking about treatment, non-operative. Well, if it's postural, can you make it better by teaching them to not sloop? Sloop. It's not a word. Not slump. And to be a slouch, essentially? Yes. You can send them physical therapy, they'll work on strengthening those back muscles, things like that, okay? But for Sherman's kyphosis, do you think they were born that way? Yes, right? So you may have to do other things. And that's what those other things are in yellow there, okay? I know I'm entertaining at least one person. So full-time wear brace though, right? So this can be something where, there's some social stigma to this, right? So convincing the child to actually be compliant with the therapy can be difficult. So we won't get into that. But there's that back brace we were talking about before. You see it? That's a back orthotic. Do you think that that is off the shelf? No. No, that's a custom, right? Everybody's different, okay? Especially me, I'm really different. But everybody's different as far as their lumbar curvature, their body habits, if you will. So these are custom made, okay? So operative, if they get greater than 70 degrees, then we start thinking about surgery, okay? And again, that's kyphosis, right? This is not scoliosis. When we talk about scoliosis later on, don't get the two confused, okay? Kyphosis is in the sagittal plane. Would you agree? It's in the lateral plane, okay? Not in the AP plane. Okay, don't get those two confused. The surgery, I'm not going to ask you about. I don't want you to know surgery stuff. Referral decisions, all Sherman's disease. Every single one of them. Send them to us. It's better to start treating them early, right? And start staving off some of the issues that arise with treatment, okay? Deformities of greater magnitude, especially if it's associated with structural components and or pain, right? So they have pain on a proportion. They have pain that wakes them up at night. Things like that. Things that just don't sound typical, especially based on the Cobb angle measurement, right? This doesn't make sense. Okay? I'm going to go ahead and stop here today, because this one's going to be quick, and we can start again next time. Okay? Give you guys a little bit of extra time to study again. Are we okay with that? Yes. All right. I'll see you guys next week.